Welcome everybody to our first Zoom virtual sports medicine lecture, and bear with us if we have any technical difficulties. Hopefully we can minimize them. We have a great lineup of speakers for you guys tonight. Our two sports coordinators, John Ebinger and Keith Levinson, will be speaking, and we're very happy to have Dr. Cilio join us from Orthopedic Associates of Long Island as well, to discuss sports medicine for the overhead athlete. And then James Hoyt, who's a World Series champion from the MLB, is going to be joining for a little Q&A later as well. Without further ado, I'm going to turn the presentation over to our first speaker, Keith Levinson.
So I appreciate all you guys for joining us tonight. I really appreciate it. My part of the lecture here, I'm gonna kick off with just talking about the phases of throwing and some basic shoulder and elbow anatomy. Remember, talking about an overhead athlete, we could talk about not only a baseball player, but a softball player, someone throwing a javelin, a volleyball player, tennis. So this is applicable to a lot of overhead athletes, but I'm primarily going to focus on the baseball player, the overhead athlete, and primarily the pitcher when I go through the phases of throwing. Not to say it's not applicable to an infielder, an outfielder, or a catcher, but the phases I'm going to talk about are for the pitcher specifically. Just to give you a little briefing on my background, a Toro graduate from physical therapy school in 2011. I hold a sports and orthopedic physical therapy specialist certification. I did a fellowship with The Ohio State University in 2018. I had an opportunity to work with the Cleveland Indians baseball team that year. I worked at the AAA level as at spring training, and I worked with the AAA team, the Columbus Clippers, for the duration of the season. And currently right now, I'm the co-coordinator with John Ebinger of our sports medicine program here at St. Charles. And I also do adjunct professor work at Stony Brook in their physical therapy department. So, we all know that throwing a baseball is a really unnatural movement, and we weren't really designed biomechanically and physically to throw a baseball. There's a tremendous amount of high forces that are generated at the elbow and the shoulder. We have angular velocities reaching 7,000 degrees per second, probably the fastest movement recorded to man to date that we know of. The body, the arm in particular, can move from a period of 4 miles per hour to 85 miles per hour with baseball in reference to that in 1.145 seconds, right? So that's extremely fast. And we have distractive and compressive forces up to about 1,000 Newton meters. So what's a Newton meter? I mean, think about maybe 4 to 5 bowling balls, 8-pound bowling balls hanging off of your shoulder and your elbow while you're trying to throw. I mean, that's the amount of force that you're generating at those joints when we throw, especially for pitchers. All right, we all know that players need extreme ranges of motion in certain areas of the upper extremity, primarily in the shoulder and the glenohumeral joint. Along with the repetitive stresses with throwing, this places a lot of risk for the shoulder and the elbow. So primarily throwing requires a tremendous amount of flexibility, strength, and coordination, not only in the upper quarter, but throughout the entire body. So here's a picture here of a thrower, a pitcher. And there's a lot of things that are going on here, a lot of things that have to go right. Otherwise, a lot of things can potentially go wrong. So some of the arrows I have pointed here, we're looking at single leg balance, stability, coordination when we push off that posterior leg. We need a lot of good adequate hamstring length, eccentric control of that hamstring when we are getting into our stride, reaching out. Also, we need a tremendous amount of core stability, core stabilization, core strength. A lot of thoracic spine mobility and flexibility. Breathing comes into play here, our accessory breathing pattern. And, I have 2 arrows here looking at, the last part here is we're looking at posterior strength. So we're talking about adequate strength in the scapula muscles, the back muscles, the gluteal muscles. These are all important when it comes into throwing a baseball. And, if we have inadequate flexibility, we can have an internal rotation deficit, which could lead to a slap tear, which is a superior labral anterior posterior tear of the labrum, or also rotator cuff issues like tendonitis or tears or things of that nature that Dr. Cilio is going to address. So we talk about, the timing of body segment, while we're moving, that's paramount and it's key. We know that throwing is a coordinated and sequential sequence of events. It goes from our toes to our fingers, which determines the amount of stress on the body and the amount of ball velocity we're going to have through the upper extremity. So we have a picture here of the motions of throwing. We go through a wind-up phase, an early cocking, we call it, a late cocking, an acceleration, and a deceleration phase. So the kinetic chain brings lower extremity energy up into the legs, which transfers into the core, into body rotation, into the shoulder blade, and finally into the elbow, wrist, and the hand. The shoulder blade is a very intricate and important part of a throwing athlete. It has to be positioned correctly. It needs proper coordination, proper strength, proper mechanics. It also has to be moving correctly with proper sequencing in order to prevent injuries and really have these athletes perform at a very high level. Excuse me. So here I have a video of a lot of you guys probably know him. This is Justin Verlander. This is when he was on the Detroit Tigers. I broke down his pitching in slow-mo. I'm going to play this video. All right, this is the wind-up phase. This is we're looking at stance. We're getting some backward motion. We want to make sure that the head is over the center of gravity. Our hands are in front of the chest and the abdomen and the shoulders. All right, the foot is under the lift leg knee. The stance knee is slightly flexed. The ball's in the glove. We're going to go through some degree of some separation here. You only want to move about 15 to 25 centimeters before separation. Play it again. The hands are going to separate when the front foot moves forwards. The elbows are going to move away together here. The throwing elbow should be below the shoulder level. And the shoulders are going to move into scapular retraction. We're going to get full separation here. So in summary, we're looking at balance point, center of gravity, trunk control, good shoulder alignment, making sure that we're facing home plate and second base. All right, moving on. We're getting into early cocking phase here. All right, this is where the lead leg steps directly in front, right on line with the vector target. The main thing here is our stride length. We want to make sure that, I can't emphasize this enough, it's 77 to 87% of the height of the pitcher. Probably more would be preferable here. All right, so we're looking at good hamstring flexibility and good control. All right. Another thing that we really want to take note of is that we really want no early trunk or pelvic rotation here. This is where the lower extremity is building up a lot of energy and the core, transferring it up into the shoulder blade. All right, moving into late cocking, we're talking about the front foot is landing, and we want to make sure we're in a good arm slot position here. We also want to make sure that we have 40 to 60 degrees of good trunk separation. We can have a lot of problems here in a lot of young throwers. We start to kind of do a little bit of some arm drag, we call it. So we want to make sure there's good separation between the lower half and the upper half, almost like pulling back a rubber band here and just kind of building up that energy before we release it. Moving forwards into arm acceleration here. This is probably our most explosive phase here. We want to see this inverse C position. We can see it at the beginning of the video here. All right, we're going to get a rapid amount of shoulder internal rotation. It's really important that the athlete has full external rotation. When I talk about external rotation in an overhead athlete, a normal individual like myself would probably have somewhere around 90 degrees of external rotation. We really want to see our overhead athletes have somewhere in the range of 115 to 120 degrees of external rotation so they can get into that really early and late cocking phase to generate those forces that they need to throw the baseball through this acceleration phase. Finally, moving into deceleration, this is our release point. We want to make sure that the athlete's finishing in a very good athletic position. We want to make sure that their pelvis and their chest is square to the target, and really want to have a good, proper balance before while they're finishing. Play this video one more time. So what comes into play here is really good shoulder strength, good shoulder stability, good shoulder endurance. Really, you know, I always tell some of the athletes that come in here is that, you know, if you have this, really your rotator cuff is hanging on for dear life, preventing your arm from ending up at home plate. So we want to make sure that the strength here is, you know, stronger than most individuals. When I do my upper extremity return to sport testing, our athlete normal population, we're looking at like 66% of a ratio of external rotation strength, internal rotation. With these guys, we really want to be in the 75 percentile. So just to go over some basic anatomy here, this is our shoulder complex. Believe it or not, a shoulder isn't just our ball and socket joint. There's three other joints that comprise of the shoulder. We're talking about the AC joint, our SC joint, and then our scapula thoracic joint, the articulation where the shoulder blade connects to the rib cage. And again, you see here highlighted in red, we have immense amount of distractive and compressive forces that happen at this joint in particular. So if you think about the slides that I had prior, we don't have good a sequence of events coordination from the lower extremity up through the core into the shoulder blade, and there's something that's kind of a disconnect along that pattern, you're going to really place the shoulder complex at a tremendous risk for potential injury. Here's some of the soft tissue anatomy. So this is the labrum. The labrum is a fibrocartilage structure. It encapsulates the humeral head slightly. It's made up of the glenoid, the glenohumeral ligaments, the bicep tendon, the long head will connect from distally into the joint itself. The function of the labrum is to help deepen the socket, increase the contact area, and create some negative pressure. But as you can see on the slide here, we know that
like Dr. Stone, where he was.
We know that the
only thing is though is like Dr. Penna will not.
We know that the shoulder is very unstable.
Doctor,
we know that only 30%
is not a hip guy, but Penna always sends his hips to.
Hey guys, if whoever just joined, if you can just mute yourself. Thanks.
So we know that the total surface contact area of the humeral head is really only 30%. So what does that tell you? I mean, here's the analogy right here. It looks like a golf ball and a tee, or we look at a volleyball on the tip of a seal's nose, right? So this is really unstable to begin with. So really what happens is there's a lot of soft tissue structures that really have to encapsulate this area and create a lot of dynamic stability. Now, along with that analogy I gave you of those bowling balls hanging off the pitcher's shoulder, really creates a perfect storm for injury in that shoulder area. So hence the reason why we need a lot of good dynamic stability, a lot of control, and we need to work the muscles of the joint. So we have the rotator cuff muscles, which comprises of four muscles: the supraspinatus, infraspinatus, the teres minor, and the subscapularis. In conjunction with that, there's 12 other muscles that really cross the shoulder complex that we have to develop, we have to strengthen, we have to make sure that they're properly trained, especially with these overhead athletes, to maintain good stability of that humeral head in the socket. Another joint I just want to bring up real quick is the elbow. Okay, so we know that the elbow is highly susceptible to injury. We see Tommy Johns happen time and time again. If you think of the elbow, it's really just a simple hinge joint. You could think of it as like the knee flipped backwards. When we're throwing, we see a lot of compressive force. We see a lot of stress in that medial elbow region where that UCL lives, right? So it's a given. We're going to get 100 Newton meters of force through that medial elbow. Unfortunately, the UCL, is only able to really take up about 54% of those stresses, and we're really relying on a lot of these dynamic stabilization muscles to kind of pick up the slack there. So really, in essence, these pronator teres muscles, flexor carpi radialis, flexor carpi ulnaris muscles, they're very vital, important to help stabilize and strengthen for the overhead athlete. We know that every time a pitcher is going to throw, it's going to generate enough force to potentially risk tearing or straining that UCL. So in summary here, having good mechanics with throwing, a good foundation with your lower body, good precision and timing, and good stability through the shoulder and the elbow is really paramount for these athletes to avoid having injury and stresses through those areas. And I'm going to lead this to Mike, Dr. Cilio, to talk about some of the injuries he sees in clinic, some of the things that we see in the office. Thank you.
Keith, that was a really great breakdown of the anatomy and some of the, relevant anatomy. I'm going to talk a little bit about common injuries that we see in throwing athletes. And then more importantly, on what we can do as trainers, parents, concerned parents, to help minimize the risk. By no means is this meant to be a comprehensive and complete breakdown of injuries and diagnosis, but hopefully by the time we're done here, everyone takes away a little bit of something that can be useful going forward. Just a little bit about myself. So I'm a Stony Brook medical school graduate and similarly graduated from the residency program there. I did my sports training at Lenox Hill in the city, where we took care of several teams, including collegiate and professional. And I've been in private practice in the Stony Brook, Setauket, and Comac area. And my area of special joints, it's the shoulder, hip, and knee. If it's other stuff, obviously we see it, but that's really my area of focus. What I'd like to do is touch on some of the common things we see from overhead athletes. And I think it's important as parents, as trainers, is to understand that when you're talking about the throwing athlete, I really break these athletes down into two categories, because kids 14 and under, and then kids 15 and older tend to see different types of issues. And that's an important thing for, as a clinician, to understand. So with kids that are skeletally immature, and by that I mean 14 and under, the most common things that we're going to see include little leaguer shoulder, little leaguer's elbow, something called OCD, which stands for osteochondritis dissecans. And then in the older athletes, you're going to see more soft tissue type of issues, whether it's at the elbow, such as the ulnar collateral ligament or the Tommy John ligament, or the cartilage, or even the tendons around the shoulder, such as the labrum, the bicep, the rotator cuff. And I'm going to touch a little bit on something called sick scapula syndrome. And then I want to talk most importantly, as I said, about what we can do to help treat and prevent these types of issues. So really the fundamental crux of our conversation tonight is, why do injuries occur in the overhead athlete? And there really are several reasons why overhead athletes are prone to injuries of the shoulder and elbow. In skeletally immature patients, it's generally an issue around the growth plate or immature bone. So the growth plate is an area, if you can see on my picture at the bottom here, this little line along the femur, and similarly this line at the tibia, that's a growth plate. And so to the untrained eye, that can almost look like a fracture, but that's where bones actually elongate or grow. And we know that from an anatomic standpoint, that's actually the weakest aspect of a skeletally immature athlete's anatomy. So immature bone is a big focus of what we do as orthopedists to help identify when there's an issue and protect. But obviously things like poor neuromuscular control, muscle imbalance, poor technique, and overuse all play a factor. I think in the skeletally mature athlete, fatigue is the biggest issue. Because when you're fatigued, whether it's because of overuse or deconditioning, that leads to poor mechanics and poor form, which puts undue stress on areas of the shoulder, elbow, or elsewhere that ultimately lead to injury. The other thing is Keith did a great job of summarizing, is that there's almost like supraphysiologic stresses put on the elbow, lesser extent the shoulder, in the overhead throwing motion. So as Keith pointed out, we know from biomechanical studies that at the late cocking and acceleration phase of throwing, you actually put enough force across the elbow at the ulnar collateral ligament that in many circumstances exceeds what we know is the maximum strength of that ligament. We're putting extreme stresses across the shoulder and elbow. And again, depending on the age of the athlete, that can lead to different types of injury patterns. Specifically at the elbow, skeletally immature athletes have growth plates over the medial part or inner part of the elbow, over the outer part, and even over the radius. And you have a combination, even though the elbow is really a hinge joint, when you throw, you don't just have flexion and extension type forces applied across the elbow. They are shear forces. They're tensile forces that are applied medially at the ulnar collateral ligament. And at the same exact time, you have compressive forces laterally. One of the things that I think is underreported, and hopefully we're addressing tonight to a certain extent, is to address a lack of awareness when it comes to overhead athletes and their risk with regard to arm and elbow injuries. And in this particular study in AJSM, what they found was that arm pain was incredibly throwing, either during sport or even afterwards, and that a lot of athletes were frequently encouraged to play through pain, which is a real important take-home point. And I just want to point out, I was talking with one of my colleagues today. I think this is going to be a particular issue this year more than ever, with the last 11 months of sports being shut down. And now we're having these compressed, fall/spring/winter sports seasons. And the reality is some kids have done next to nothing. And even other kids have been playing, travel ball. I think this year more than ever, as caretakers, whether it's as a trainer, a parent, as a physician, a therapist, making sure that we're encouraging our athletes to communicate what they're feeling is incredibly important, because I personally am concerned that the risk of injury this year is higher than ever because of what we've been dealing with for the last year. Very, very superficially, as I said before, I like to divide throwing athlete injuries into youth and then skeletally mature. I think the three major things you'll see around the elbow in a skeletally immature, again, 14 and under athlete, is going to be little leaguer shoulder, which is essentially a growth plate injury at the proximal humerus, the upper humerus. Little leaguer's elbow, which is going to be medial sided or the inner side of the elbow pain, and then OCD or osteochondritis dissecans, which is an injury to the capitellum on the radial side. And the goal of bringing this up isn't to give you all the nooks and crannies you need to make these diagnoses, because frequently it involves imaging. But I think the take-home part is that kids, and by kids, I'm sort of defining them as, again, 14 and under, they don't sprain their elbow, they don't sprain their shoulder. That's just not how it works. Kids are not small adults. They're different anatomically and physiologically. So for me, when I hear things like I have difficulty loosening up, I can't seem to throw as hard, I feel like my elbow is stiff or my shoulder is stiff, any kind of swelling, to me, those are red flags that generally should encourage the athlete to seek to further evaluation and care. And again, the appropriate rest and a diagnosis early in these patients is really paramount. In the older athlete, as I said before, much more frequently you're dealing with soft tissue type of problems, whether it's a simple tendonitis or bicipital tendonitis, rotator cuff tendonitis. I would say the thing I see in my office most frequently is actually scapulothoracic asymmetry or scapular winging and GERD. And as I'm sure a lot of you guys know, GERD stands for glenohumeral internal rotation deficit. It's easier to say GERD, obviously. And essentially GERD is when you are developing asymmetry in the range of motion of the throwing shoulder, where as an adaptive mechanism, overhead athletes tend to get more external rotation or bring their arm up from there posteriorly, but they tend to lose internal rotation as the range of motion of their shoulder shifts or adapts to allow them to throw. And while in some respects that it seems like that'd be a good thing, a lot of times it's not, because such asymmetry can lead to issues such as internal impingement, where the cuff gets impinged between the glenoid and the humeral head. And there's actually some interesting literature in professional level athletes that show that patients with significant differences in their motion between the shoulder can predispose them to issues downstream, such as at the ulnar collateral ligament. So any athlete that you see, or any athlete I see in the office who comes in complaining of elbow pain gets a full shoulder exam as well. And you pick up on this all the time. And I can't stress enough how, an ounce of prevention is worth a mound of treatment. So that's the take-home point here. And really the last thing I want to touch on is how do we protect our athletes, which John is going to elaborate on this a little bit more. I think, in 2021, we're doing a better job of protecting our overhead athletes, and the Little League International Safety Organization has recommendations with regard to pitch count. And I think this is much more just like concussion care 6, 7, 8 years ago, and it's much more accepted now what we're doing. I think pitch counts are much more embraced by both athletes, coaches, and parents. I still feel that there's not a perfect consensus on what the appropriate pitch count should be, but I think this slide sort of summarizes it nicely. Is in addition to this, there are recommendations where the more pitches an athlete throws, the longer the number of days of rest should be. So for an athlete 15 and under, once you hit 70 pitches, I believe it is. You should have at least 4 days of rest, and down from there. For a kid 15 and older, they bump it up to 80, 85 pitches before there should be a period of 4 days or longer of rest. And I think, again, rest and pitch counts go a long way in managing is paramount. Did I freeze again?
No, you're good now.
Okay. You got to make sure that you're listening to your athletes, and athletes are listening to their own body, and the importance of a specialized team who understands the throwing athlete specifically is invaluable. And then obviously, someone like me or another orthopedic sports specialist who understands what the throwing athlete deals with is helpful and imaging when appropriate. And I'm not going to go too much into this. I know Keith wanted to break this down, but again, it's not just the shoulder, it's not just the elbow with these athletes. It's looking at not scapulothoracic strength and rhythm, core strength, and the lower extremity as well.
Hey folks, my name is John Ebinger. I am one of the sports coordinators with Keith Levinson. It's very nice to be part of this conversation, pulling in the anchor role with some great talks by Dr. Cilio and also Keith. Some of what I'm going to be going over will be a little bit of some concurrent review with the things that were discussed prior. But know before you throw a clinical approach to the overhead athlete, in particular, how we as sport PTs and as well as orthopedic physicians in sports medicine will address some of these issues. So the prophylactic injury prevention screening is vital. So look at this as an orchestra, if you will. So the whole is greater than the sum of the parts. It's a symphony of things that have to take place in precise order of operations in order to have painless and effortless throwing with the overhead athlete. So Keith had mentioned before the kinetic chain. This is something I'm going to touch upon briefly, but look at this as almost like wrenching a coil. Once one checks out, the next block builds up, and then the next and the next. And this is where we're going to efficiently build this potential energy, which is going to allow seamless transition to release the ball. What we're doing in global retrospect to this injury prevention is looking at what we refer to as modifiable risk factors. These are things that biomechanically we can address and educate and also change in the throwing athlete that can help reduce. We can't eliminate, but we sure as hell can help reduce the risk of injuries with these athletes. So the kinetic chain, what is it and how does it affect me? It's a notion that these segments have an effect on one another. So it's a cross-link or linkage. We look at the ground, which I'm going to go into in a second, from a ground-up philosophy of how we deliver all this power to throw a ball. If there's a break in the chain, unfortunately, the body is very, very smart, and it's always going to find a path of least resistance, and that's what we don't want. That path is going to lead us down a road that could lead to potential injury and unfortunately, sometimes a season-ending one. So injury prevention here is key. So Drake once said, started from the bottom, now we're here. So let's look at the foot and ankle. So range of motion in particular is important. I don't get in particular with the pitcher's foot placement on or by the mound, but strength for push-off is important. So we're looking at eversion strength of the ankle. So push versus kick. The main takeaway here is I want athletes to understand, look at it as if you want to stomp on a soda can. You want to crush it. You want that force to be pushed into or off of that mound as best as you can. And this is really what's going to set the stage with that kinetic chain. So the corkscrew, the hips, Keith mentioned, talked in detail about the importance here. So part of our screening is not only looking at balance, we're looking at strength using handheld dynamometers, but really the disassociation here of the trunk. So in this depiction here, we have A, B, and C. A is a frontal view, B is a top view, C is a sagittal view. I want you to take focus on picture B. This is a great depiction of how we look at that separation as he's getting into quickly late cocking and vastly quick into acceleration. We want to see that separation. We don't want to have the trunk leading the hips, and we don't want the hips and the trunk moving simultaneously. There has to be that disassociation. A great way to depict this, as you can see in figure C, is with one of my pictures when we look at towel drills. So I'm going to take the audio off of this, but this was taking at 280 frames a second with 2D motion that we use in the office. And folks, we can use this on our cell phones. This is very readily available technology. So I'm going to pause it here for a second as he kind of comes into his windup. I want you to notice that he really starts to lead with those hips. His foot on his lead leg is at the target where the tape is. I'm going to pause it right. Oh, sorry. I'm going to pause it right here. I'm going to bring it forward just a bit. I know there's a little bit of a delay here. And really, once he gets through that motion and he lands right there, Now his trunk is going to start to come through as he gets to late cocking into acceleration. The big key here, and I want you to all remember this, is that the shoulder is going along for the ride. If they're quote unquote muscling the ball, this is where there's going to be problems. And if you notice, as his trunk starts to rotate, there's very little motion happening at his shoulder. He's going to start following through here. And as you can see, he slaps into my glove, and there's his deceleration follow through, which looks pretty well that we've been working on in the clinic. The core foundations, proximal stability for distal mobility. This is a big one. So what am I talking about here? When we look at core muscles, a lot of times people reference their beach muscles, the big muscles, the rectus, the external obliques, the things that look good. But really the starting point here is we want to look at the deeper muscles, your transverse abdominis, your internal obliques. There's ways that I'll show you in a moment of how we can at least elicit contraction of those muscles. It's very hard. Literature goes back and forth on this, on ways to isolate. But I think if we have techniques of abdominal hollowing and ways that we can have at least have athletes have a kinesthetic awareness of how to target these muscles, I think we'll be off to a really good start. Thoracic mobility. Dr. Cilio and Keith showed this, and this is the same photo that we've all shared. I mentioned briefly about rotation, but look at this reverse C. Look at this extension that he's going to go through as he gets into acceleration. This is really where a lot of this energy and power is going to go through. It allows for a proper slot position, and it really is this precursor of this thoracic spine in extension that we can help mobilize and go through specific exercises that it's going to allow for this proper transition into acceleration. Posture is everything. We look at this all the time. Stretch what's tight, strengthen what's weak. Poor posture at rest is going to equate to even worsening posture with activity. So if you look at this X marks the spot, what's typically weak that we see in these athletes? They have a forward head posture, so the deep cervical neck flexors are weak. As you cross-link that down into the posterior back, you're going to see weak lower and mid trapezius and your serratus anterior. I'll touch on these briefly, but these particular muscles are vital with upward rotation of the scapula, which is going to be important for that slot position so that elbow doesn't dip as we get into late cocking into acceleration. And commonly what we see tight is the beach muscle, the big pecs, pec major, minor, always tight, protracting athletes forward. We want to loosen those up, and the upper trapezius will typically compensate and upwardly or elevate the shoulder blade, which is what we don't want. The scapula, Keith talked about this a great deal with the anatomy. I won't get into it too much, but the thrower's paradox. This is a coined term that we talk about. There's a tremendous amount of mobility in the shoulder. It's the most mobile joint in the body. However, the trade-off here is intrinsic stability. So with athletes, it's a fine line that we run with holding the amount of stability that we can carry these athletes with without injury, but having the proper amount of motion to allow the powers and energy at A to deliver a ball well. In a moment, I'm going to touch upon a few things. Humeral retroversion, GERD, which Dr. Cilio mentioned prior. Strength we look at with the microfit similar to the hip, and as I mentioned prior, common thread here is what's weak, those upward rotators of the lower and mid trapezius, your serratus anterior, and the decelerators of the rotator cuff that Keith touched upon a little bit before, which are coming from that infraspinatus and teres minor muscle that is really important with that deceleration. I look at that as when and if you can pump the brakes. So humeral retroversion, this is a fine line too. It's almost borderline thrower's paradox when we look at these, young individuals, 14 or under that Dr. Cilio mentioned. This is a bony adaptation that takes place with open growth plates. So if they're not going to have an apophysitis, so this, little league shoulder in particular, we're going to start to see a bony adaptation as they continuously go into late cocking and that external rotation motion, that humerus is starting to torque and torque and torque. You're going to see that. So the depiction on your left is showing what would be probably normal internal rotation, getting close to 90 degrees. But as you can see on the picture on your right, this is a depiction in a passive state of looking at that bony adaptation of this is his just normal, comfortable resting position of his internal rotation. So there's a big difference here. What I want to emphasize is if we at least address this and we understand what bony adaptations are taking place, you may not want to be starting to stretch these kids and working a ton of the posterior capsule to get them more internal rotation, This is a safe compensation if they're not having pain when they throw that we might want to see with some of these athletes. GERD, as Dr. Cilio mentioned, is this internal rotation deficit, but you really have to look at two things. Yes, we look at internal rotation comparing side to side, But another thing that we want to address is pitchers are a lot different than my shoulder, who doesn't throw, if you were a position player, but we really look at the total arc of motion. So if you look at these two pictures, left versus right, one would say, wow, look at that amount of internal rotation deficit on the right versus the left. But you have to add these totals up. So we're still getting 180 degrees of rotation, adding external and internal rotation. So the key here is if we really start to see a greater than 5-degree discrepancy, left versus right, where they're non-throwing versus their throwing shoulder with this total arc of motion, this is something that we might want to gear in towards more rather than, or at least identify, than just an isolated internal rotation deficit by itself. Keith mentioned before, a major stabilizer of the UCL, or the medial side of the elbow, is the dynamic stabilizers of the forearm. So we really want to make sure that we're attenuating and working on forearm flexor strength. Understand the flexors, as is the forearm extensors, they cross multiple joints of the wrist as well as the fingers. So we want to work on grip strength and forearm flexor strength combined. So what do we do from now? A lot of times, I'm not a pitching coach. We want to keep this as simple as possible. So keep it simple, stupid. We're addressing modifiable risk factors, which is key in early prevention. So a lot of times when we screen these athletes, we're really providing them a kinesthetic awareness. I have had athletes that at the collegiate level that have conditioned and they look fantastic from, just from a observational view. But when we start tackling some of these finer things, they really will realize the weaknesses and the deficits that lie beneath that we really need to address. To highlight some of the things that Dr. Cilio did a fantastic job is knowing the warning signs. So know before you throw. If you are having, and this is geared towards the athlete, I want you to take this home and remember this. Don't hesitate to let your coach or your parents know. And for parents and coaches at home, it's important that you understand what is happening here. But shoulder and or elbow pain when you are throwing is a major red flag. If they're having pain when they're throwing, breakdown is occurring. And if they continue to do this, the pathology there is going to continue to compound and compound. And by the time you get to me, or by the time you get to someone like Dr. Cilio, it might be too late. Pain or soreness 2 to 3 days post outing or post bullpen session is a sign that we want to make sure that we're looking at. Tenderness to any area of the shoulder, medial elbow, any aspects of the shoulder or the periscap around the shoulder blade is something we want to make sure they're addressing. Dr. Cilio mentioned before, you just can't get loose. I've stretched, I've done my warm up, I'm feeling tight. And then if they even feel like they got loose and they're on the mound, but they're starting to lose velo or that velocity, and they're losing control and command, that might be an early indication that problems are arising. So I'm just going to go through these real quick. These are kind of on the KISS method of exercises that will get athletes to start working on indoor stretches. So loosening up the calves, making sure the calf soleus complex is loose, working on those everters and strength of the ankle. Hip flexibility, strength and balance, all important here. So the first picture on your left is going through kind of a star pattern, working on single leg stability, working through different patterns, combining different types of alternating marching bridges and TheraBand hip flexion work and glute work is important. Range of motion here is vital. So looking at your internal and external rotators, especially looking at the differences in your drive and your lead leg is important. Trunk rotation, so that separation. So a lot of times the top right picture is part of our exam that we'll look at to see if athletes have adequate thoracic rotation. A stretch here you can do on the top left, and looking at these prayer stretches or some foam rolling could be a way to kind of work on that thoracic extension or that reverse C that Keith mentioned prior. Core stability, this is where I talk about the transverse. So you want to work on some abdominal hollowing, working on some what we call posterior neutrals. Start working in ways that are without movement. So a key example here would be looking at some isolated plank on elbows, and then gradually, once you build up some of that stability and they feel comfortable there, we can work on some movement patterns, doing some dead bugs, some side planks with some rotation might be a good lead in, and then progress from there. Periscap musculature, Dr. Cilio highlighted some of these slides in his presentation, but we call these your I, Ys, and Ts, looking at your rhomboids, your lower trapezius muscles, and again, those upward rotators. So the serratus muscle, looking at those two depictions on the bottom, are important. So these are good examples of how to work that. Rotator cuff strengthening, Keith highlighted this with those decelerators. So your infraspinatus in particular and your teres minor, completely outmatched by those big internal rotators. So we want to work these in various positions, working on concentric, eccentrics on the right, working on eccentric or those negatives on the top left, and going through different positions. Take, for example, the bottom center picture in that 90-90. Capsular stretches we might prescribe, but be careful if we're looking at a true humeral deficit. Then this might be something you want to look at. But the focus on the top right picture, I'll kind of wrap this up soon. But the top right picture is an example of a sleeper stretch. If you notice, he's kind of gearing and leaning more towards his left than he is all the way onto his right. We refer to this as a modified sleeper. The reason why you want to do this is if you have the athlete roll all the way onto that shoulder towards the right, you're gonna start looking at possible impingement of the shoulder. So we open them up a little bit. We kind of have them like 3/4 towards sideline in that position, and you could also do this varying position against the wall too. So there's a couple of options there. Real quick, we utilize BFR a lot, but working those forearms. So forearm program, wrist flexors, extensors, deviators, looking at your supinators and pronators, as well as some eccentric control of the bicep, which is also important in your deceleration. Last here is arm care. One size does not fit all. So to highlight again what Dr. Cilio mentioned is an ounce of prevention is worth a pound of cure. So based on these deficits that we're seeing with these athletes, we really want to be very specific with exercises that we're giving them. So for example, this is an athlete, again, really, really great musculature, big pecs, big lats, big legs, but his periscap was for crap. So a lot of these exercises we're giving are some perturbation work, some plyos against the wall, 90-90s, clocks, sideline, external rotation with plyo. Just to give you an example, I don't want to play this all the way through, but these exercises, as simplistic as they look, he will be sweating, he will be grunting. They are not easy. I just want to fast forward to this one here. This one we refer to as a Blackburn. So this is a way to work on core control and also his periscap. This, folks, he had a lot of difficulty with. He did this for maybe 7 or 8 reps. This is a dowel that weighs probably less than a pound. So yeah, he could do lat pull down for days, probably looking at 200 pounds, but he can't even do a dowel over his head with 1 pound. So these are things that we want to really make sure that we're focusing on. And last but not least, the disciplinary approach, combining the orthopedic and the rehab side. So Dr. Cilio, we were so thankful for having you here and as a representative from Orthopedic Associates of Long Island, but a great service that they do offer is the urgent care. So there's no wait here, folks. So from 4 to 8, Monday through Friday, access, offering on-site digital x-ray, MRI, anytime that we have athletes that we're very concerned about, their doors are open. We get athletes in there as fast as we can. And in addition to that, we have our sports recovery, both Sundays at both COMAC and CenterH. And we do offer recovery and these, on-site assessments of athletes. So coaches, if you have an athlete that has something you're concerned about, by all means, I'm going to share both Keith and I's information, both for our offices and our emails. Feel free to reach out to us if there's any concerns that you may have with an athlete. I think my time might be up. I tried to get through that as quick as I can. So I'm going to pass this back off to Laura, and hopefully we can get James Hoyt on, and then we could start some Q&A as soon as we can. That wraps it up for me, folks.
James, welcome. So I know James's time is limited, and I really appreciate him coming on tonight to share some of his wisdom, his experiences throughout his professional baseball career. Just real quick, I want to introduce James. James was born in Boise, Idaho. He attended the Seminary College in Louisiana. He started his professional baseball career in independent baseball. He actually was a non-drafted free agent. Walked on with the Houston Astros in his time there, in his stint there. He won a World Series title in 2017. I got a chance to know James during my time in Columbus with the Cleveland Indians. He went on to continue his career with the Indians until 2020. And just recently is a new member of the Miami Marlins. He's a starting pitcher for the Miami Marlins. So I'd like to welcome James. Thanks for joining us, James.
Of course, Keith. One more thing, relief pitcher, not starter.
Relief pitcher.
I wish I was starter. They make the big bucks.
How's everything going? How you been?
Everything's good, man. Yeah, good to see you, and thanks for having me on.
Absolutely. Thanks for joining us. So I know your time.
Sorry, I'm in my car. Sorry, I'm in my car. I have to be somewhere soon. That's why.
That's okay. Yeah, no worries. So I know your time is limited, so I figure we get right into some Q&A. A question that I have for you, and I'm sure a lot of other people might be wondering is, what do you find to be the big difference in the medical care that you experienced during your high school days, moving into your college career, and now while you're in professional baseball? How have you seen things transition and evolve with the type of medical care that you've gotten over the years?
Sure. Yeah, sure. I think a big aspect of that is the science. Everything keeps changing. They keep coming out with newer and more advanced technology that we can use as athletes to better ourselves when it comes to recovery and whatnot. But for myself, I think the biggest thing is relationship. You build a relationship with this PT or athletic trainer or strength coach, and just the knowledge back and forth comes, at such a higher level. That was the biggest change for me.
Yeah, so I mean, it seems like the medical staff is a huge component in what you need to do on a daily basis during the season, in the off season, before the games, during the games, after the games. So how would you rate on a scale of maybe 0 to 10 how important the medical staff is to you? And that includes the doctors, the physical
Mhm.
therapists, and the athletic trainers.
I mean, yeah, they're right up there with, everything you got to do. When it comes down to, especially at the major league level, that's why I'm talking as far as baseball. It's kind of like what you put into it. So however much you want to put into it is what you're going to get back. So I see guys all the time. They don't do, they don't focus on training work or recovery or sleep. And, a couple of years goes by, I see one have a surgery, another one, a different surgery. And then they're kind of out of the game. So for me, it's always been like what you put in, you're going to get out.
So, kind of feeding off that question, I would say it's safe to assume, I mean, I've been there, I've worked with you guys, that the off season is super important for you in terms of taking care of your body, your workouts, your conditioning, your nutrition, arm care. Maybe you can explain a little bit about some of the things that you do to take care of yourself that you find to be very valuable and important.
Yeah, sure. Like you said, off season is almost just as important. I think more important. I've kind of bounced back and forth. I've taken an off season off. I've taken an off season in winter ball where I kind of keep pitching. And then, for example, this season, all I did was hammer my PT and my strength, and et cetera. But examples of kind of like stuff I do, I saw right when I got on, you guys were talking about the BFR. That's a big machine that has kind of helped me get back to where I am. I've had a knee surgery, elbow surgery, and it's just been that's been good work to do as a BFR. Let's see. Honestly, a lot of hands-on care. So for me, I can talk over the phone to someone and they're going to tell me a program and do this, and you want to strengthen this. But for me to have the hands-on PT, it really takes my game to another level. At least my body. At least I know my body's prepared and ready to go into it. So, whether that's manuals, some form of stretching, soft tissue, acupuncture, the laser, we use a lot of different things here. And I'm very fortunate to have access to these, to a PT and to the resources.
Some of the previous talks that we had before you signed on, we were talking about the importance of arm care, of keeping your shoulders strong, keeping your elbows strong. What are your thoughts about that? And what are some of the things that you do on a daily basis to take care of your shoulder and your elbow?
Sure. Yeah, I think that's number one. I mean, as a pitcher, everyone's different. Position players, they can kind of just roll by the off season, start working out. Oh shoot, sorry, I got a call. I got to delete. I'm on my phone. That's why. Let me see if I can do it. Hold on. Okay, decline. Am I back?
Yeah,
You're
you're
back.
good.
Okay, we got you.
Okay, sorry about that. Let me turn it off so no one can call. Okay. Should be back. Okay, so back to that. Yeah, for me as a pitcher, arm care is number one. I always have a routine I go into. So as soon as the season stops, I usually take a couple weeks off, and then it's strictly arm care. I got to get back to kind of equal is how we call it. Because throughout the season, it's so much wear and tear in your arm and just the grind. So especially as pitchers, everything wants to kind of go forward. Everything seems to kind of tighten up a little bit. So that PT and the arm care I do is helping me bring everything back. That's mostly what I do before I do any type of arm throwing program. So say I say the season ends in October, I'm probably not picking up a ball till December. So I'm going to take a whole month of kind of focusing on arm care, and just my whole body kind of equaling out the imbalances I have, the bad tendencies I developed over that season.
Nice. I don't know if John, if you have any questions for James or Dr. Cilio that you wanted
Or
to ask.
if anyone
do.
has any questions too, you feel free to raise your hand and I'll unmute you also.
James, good to see you again. It's been a couple of years since Keith and I went out to see you in Lehigh. I hope you can hear me well, and that you're doing well down in Florida. But I have a question. I had the opportunity to watch a short series from Link Soldier that was came out a couple of years ago, I want to say. And, you know, what really resonated for a lot of the pitchers that we see here at the Little League and even the high school level is, you know, you talk about how, you know, you weren't really heavily recruited as a high school player, you know, as you went through college, you know, wasn't really kind of getting the looks that, you know, everyone goes to strive for. But there was a comment that you made that, you know, I think really hit home. And if you can elaborate, is that you said you had to go out and find it. Can you, you know, kind of elaborate on what exactly, for someone that you could speak to, the common, you know, pitcher out there, what exactly did you find and how did it, you know, lead to where you are today? I think he's on. James,
he's muted.
Mute. There you go, bud.
Unmute.
Yeah.
Okay, probably kicked me off. Can you hear me all right?
Yeah, you're good.
Okay. Yeah, so like I was trying to say, you know, baseball is such a hard sport. You know, there's so many people, there's so many players, and you have this whole development program. You get such big time prospects in high school, and you know they get paid millions of dollars by these organizations. They kind of draft them, they develop them, and then you have kind of like outskirt players who, you know, maybe played college ball, they want to keep playing, but you know they're not good enough to be drafted. And I can easily say, you know, that was me. I was kind of on a point where, you know, do I really take this? Like, do I keep playing? Do I keep taking this path? Like, I didn't really know what I wanted at the time, but then once I figured out what I wanted to do, that's what I had to do. And that's kind of what I meant. Like, I had to go find a way. I had to find a way for them to, you know, recognize me, them to see me. So it was just, you know, honestly, for me, it was just grinding every way I could. If I needed to keep playing, it didn't matter if it was a different country. I went to 3 or 4 different countries to play winter ball and just to, you know, further develop my skills. And yeah, I just kept, you know, hard work and faith and kept going, and you know it landed me in the right position where I wanted to.
Fantastic.
Hey,
Great.
John, I'm going to interrupt. I see we have a question from Nicholas Trabacci. And
Yeah.
you should go ahead.
Go ahead, Nick.
So John, I just had a question about, so you said you're a relief pitcher, and I just got Tommy John surgery, and this season I might be coming out of the pen. So I had a question for you about, you know, what's your routine like? You know, if they call down, they're like, hey, like you have to get hot, you have to get quick. What do you focus on really? Do you focus on like getting the core temp up and just, you know, getting the body ready to move and then start throwing pitches off the mound, or like what do you do?
Sure. Yeah. Good question. Everyone's different, you know. When you get to this level, you kind of realize what you need as a, you know, as a pitcher to get ready. So a big aspect for me is, you know, I always watch the game. I got to watch the game and kind of see how it's playing out. See, you know, is this okay? Could I maybe pitch this next inning? And from that aspect, you know, I got to stay ready. So, but I've seen it also, you know, I got to move around, you know, maybe build up a sweat somehow, do a little stretching, throw some weighted balls. But I've seen it also, man. I've seen some really good players that just they can just wait, you know, they can just stand up, tie their spikes and get on the mound and start throwing. So I think everyone's different, everyone's unique at that aspect. And you know, but for me, like I said, just, you know, prepare, whether it's before the game, I got to make sure I'm loose. So then when I do have to throw, you know, maybe only 5-10 throws and I'm ready to go.
Awesome. Thank you.
You're welcome. And good luck.
Thank you.
Does anyone have any other questions? John, did you?
Looks like Dylan has a question.
Dylan Love?
Yeah.
Oh, yep, I see you. Okay, I'm going to ask, sorry. Go ahead, Dylan.
Hey, James, thank you for your time, first off. So relievers, they kind of, they're always on call. So I was curious what your process is, at least like day to day, in terms of being ready, since you can be called on at any point in time, and kind of how you stay fresh and how you stay hot all the time when you
Mhm.
knowing that you have to be on call day-to-day basis?
Yeah, good question. And I think the biggest thing for me is preparation. How am I going to be able to tell the manager every day, hey, I don't need a day off? That's the hottest commodity as you become, say my position, I'm a relief pitcher, right? Okay, what do I have to do to be best, go out there and give it my best and to have good success? Well, number one, I have to be able to take the ball. So I got to be healthy. So, that starts in the off season. That starts with arm care. That starts with, preparation in the gym, diet, sleep, everything kind of adds up. It's one thing, being in your house, comfortable, going out there, throwing, playing catch, but then it's a different thing when, you land in New York City, it's 3 a.m, you get to the hotel, you might get to sleep by 5, and you got a day game at 1 o'clock. Like that's the grind, your everything's different. You got to see how you can react in an uncomfortable situation. So for me, it's just being able to take the ball as much as possible. And, that's the rest kind of speaks for itself. Like if you do that, you just put yourself in a good position to succeed.
Thank you.
Hope that helps. Yeah.
Thank you.
Thank you.
Any other questions? John, did you have any other questions? I know you, or you,
I just,
James.
just to ask James real quick. I know he's pressed for time. He has to go.
No, we're good. I got 10 minutes. We're no rush.
Okay, good.
All right, great. Yeah, great. What type of advice would you give a young high school baseball player or college baseball player? What type of advice would you give them looking to get to the next level in terms of just whatever it is that they need to do to get there?
Mm-hmm. Sure. Yeah. High school student, what you got to look at what's important, right? Well, obviously grades. So I would always just go back and check the boxes. Okay. So, if I want to put myself in a position to play, number one, I got to be healthy. You got to be healthy. You got to be able to compete. But number two, if you're a high school student, where are you going to play? You want to play pro ball or you want to play college? Number one thing, these scouts, these teams, whether it's a major league organization or, a Division I school, they're going to look at your grades. So, obviously you got to keep the schoolwork going, take care of the body, just focus on the little things. People always say, don't sweat the little stuff, but when it comes down to, if you want to play in the major leagues, you really got to sweat, you got to focus on the little things and do them. I wish I would have done a lot of different things earlier in my career. I felt like that would have helped me out later. Keith saw it firsthand. We were over there at Ohio State running in the underwater treadmill.
That's right.
From a banged up knee. So, I wish I would have done things earlier in my career to kind of, prepare myself to not go through that. But, as another thing with a high school student is, you're always going to have a fork in the road. I think when one door closes, there's always another one that's going to open. I was never drafted. I went to a small Division I college. I didn't pitch a lot, but I just kind of kept filing away and just kept kind of getting a little bit better each day. And then boom, one thing led to another, saw an opportunity and just took it and kind of rolled with it. So I hope that answers your question a little bit.
Yeah, that's great. Really good information for the young players today.
I'd also just kind of like emphasize, just the importance of taking care of your body. There's a difference. You can go to the weight room every day and just do, stuff to build muscle. But like I saw in your, earlier when I got on, I see so many big guys and they're so, they look good, they're strong. They got big legs, big arms, but their smaller muscles, the ability to move their scaps, and protract, retract is very hard. And I think, as an athlete, that's huge, is you got to really fine tune the little stuff in your body, mechanics, and the small muscles.
Definitely. We couldn't agree more. And that's where we come in, right? The trainers and the therapists, that's what we do. That's our wheelhouse. So that's what we're there to help you with. John, you have any other questions for James? Anybody else in the audience?
Just kind of a side note or a joke, but the car seat's pretty packed. You got your Mark Pro packed in there somewhere?
You know what? I got a Mark Pro and I got the Theragun. They're ready.
You're ready
Yeah,
to go.
I have to go. I'm in San Diego. My car's getting sent to Florida tonight. That's why my life is in here right now.
I bet. So absolutely. But I do appreciate all your time. That was great.
Sure. Thanks for having me, guys.
Absolutely.
James, thanks for coming on. It's great seeing you, and wish you luck with your season, the upcoming season.
You too, buddy. We'll be in touch, and
Yeah,
thanks everyone
absolutely.
for listening in.
Absolutely.
All right.
Thanks, James.
Okay, we'll see you guys.
All right,
Take care.
take care.